There are a lot of unmet needs in these patients. One of the things to think about is the prevention of sudden cardiac death. And even though for many years we have known that the implantable cardioverter defibrillator is beneficial in these patients, the publication of the Danish trial that came out in September of 2016 led some to question whether ICDs are beneficial in those patients. And so that required some groups, including our team, where we did a meta-analysis of the different clinical trials of primary prevention ICDs in patients with non-ischemic cardiomyopathy, and still showed a 25% relative risk reduction in all-cause mortality with the ICD. So hopefully we can continue to learn more about better selection of patients for ICDs, because I would be the first person to admit that not every patient who receives an implantable defibrillator benefits from that therapy. And there are patients with non-ischemic cardiomyopathy who don't fall into the category of an ejection fraction of 35% or less. So we certainly need to improve the selection of patients with non-ischemic cardiomyopathy for the prevention of sudden cardiac death. So certainly the biggest challenge I'm seeing today is that, as I said, the publication of the Danish trial has led some physicians to question the role of the implantable defibrillator in those patients, mostly really among our colleagues, the general cardiologists, who are now questioning, are these devices beneficial in those patients? Do we refer our patients? In fact, some people are not referring their patients to the electrophysiologist to have that conversation about, the benefits, the risks of the ICD. Obviously, we all believe in, shared decision making in terms of presenting patients with evidence and data on benefits and risks, but what actually this information means to them in terms of their personal goals for their health, their values, so on and so forth. So I'm hoping that as we publish more data on better selection of patients, and that will improve.